Hi guys, welcome back. This is Dr. Deepak Marwah and now we shall be studying regarding MCI June 2018 paper. Pretty a straightforward and a balanced paper, I would say. So let's start with the very first question. This will be one of the very easy ones. The question simply said what is the sensitive and a specific test for iron deficiency anemia, and all of you know the answer. I mean, you would be rather hunting for the answer in this kind of a question, that is serum ferritin levels. This is both a sensitive as well as a specific test. Because serum ferritin is the first one to fall, so therefore this is a good parameter to identify iron deficiency anemia. The only problem with this test is that when serum ferritin will fall, patient will always be symptomatic, so I cannot say that this is a good test for early identification of the disease. If the question says that for early identification of iron deficiency anemia in the initial phase of the illness, what test would you like to do? So we can be going in for a serum transferrin receptor population. This value would definitely be upgraded. Why? Because of the compensation. The body will try to absorb more iron. It will try to basically assimilate more iron to take care of the deficit which is present in the body of the patient. For screening, other tests which are available are zinc protoporphyrin levels, ZPP. Another test which is available for screening purposes is RDW, that is called as red cell distribution width. The values of red cell distribution width in excess of 14.5% are suggestive of the presence of microcytic hypochromic anemia in the patient, though the problem is that microcytic hypochromic anemia can also be present in thalassemia trait. So these tests can definitely not distinguish between iron deficiency anemia from a thalassemia trait. The limitation of these tests is that they can just help you know that yes, there's a dimorphic cell population, there is a presence of a microcytic small RBCs with rather a less amount of hemoglobin. In fact, if you look at this slide that I just show you, you will see RBCs of varying sizes and shapes. In patients of iron deficiency anemia, you will notice that the shape of the RBC as well as the size of the RBC will change very dramatically. This would be called as anisocytosis. And also there's a change in the shape of the RBC, so we are going to call it a poikilocytosis. I repeat my statement again. Anisocytosis would mean a variation in the size of the RBC. The triangle means variation. Poikilocytosis would mean change in the shape of the RBC. I'm just going to put some pointers to highlight these varying looking, varied shape looking red blood cells present in the patient. And yes, I can definitely notice some of the RBCs are having some amount of a hypochromia. So this is definitely a slide which I would say is a little skeptical one. I've just kept that skeptical side because I just wanted to zoom in, and you can see some ghost cells present here also that actually look like schistocytes. So these could either be artifacts or they could be rather a slide which has not been well made. But at the same time, I just wanted to show this slide to you to highlight the fact that whenever you get such a slide with a gross variation in the size and the shape, then iron deficiency anemia should definitely be kept in mind in patients who are having a low hemoglobin. What are the conditions in which the transferrin receptor values will be less? That would be erythroid hypoplasia. That could be conditions like aplastic anemia. I mean, common sense, right? Bone marrow is damaged, so there would be a low transferrin receptor. Since in this condition there is no possibility of the body trying to compensate under any circumstances if the bone marrow itself is damaged, the factory is damaged. But reason for raised transferrin receptor values would be conditions like iron deficiency anemia, chronic hemodialysis, and even thalassemia. And this test is definitely not going to have any variation in anemia of chronic disease. The type of anemia in anemia of chronic disease which has also been asked in your MCA exam is normocytic normochromic anemia. When I will say that, a lot of you will say that we have read or pathologist has said that this kind of anemia of chronic disease is seen in microcytic hypochromic also. I don't dispute that, absolutely no issues with that. But yes, the problem is that the incidence of normocytic normochromic anemia and anemia of chronic disease is more as compared to that of microcytic hypochromic anemia. So therefore, you should answer normocytic normochromic as primary answer for anemia of chronic disease, and this has been asked in the exam. Coming back to the main question, just remember the most sensitive and specific test to diagnose iron deficiency anemia would be answered by you as serum ferritin levels. Moving to the second question. The question says in alpha thalassemia trait, the electrophoresis will show. Now the point is, guys, when it comes to the topic of alpha thalassemia trait, electrophoresis is not a very good test. In fact, most of the time electrophoresis will fail to identify the presence of alpha thalassemia trait in a patient, in a sense that in these patients you might be having a normal fetal hemoglobin and a normal hemoglobin A2. Therefore, the best test for evaluation of thalassemia remains HPLC, that is a high performance liquid chromatography. I presume the fact that this question was asked in the exam just to see whether you are aware of the fact that serum electrophoresis or hemoglobin electrophoresis as a test for identification of hemoglobinopathies is okay when I say it as a screening test. Though for screening purposes, we can also be having a naked eye single tube RBC osmotic fragility test. Hemoglobin electrophoresis can be used for identification of hemoglobinopathies, but it can miss cases with respect to alpha thalassemia trait, which is the reason why you will anyway have to do a HPLC. If he says what is the investigational choice for diagnosis of alpha thalassemia, or if he says what is the investigational choice for diagnosis of beta thalassemia, or he says what is the best test for diagnosis of sickle cell anemia or any hemoglobinopathy once per se, the answer should be given as high performance liquid chromatography. HPLC is the best test to identify. I'll just show you a slide which is showing electrophoresis. If you compare the normal pattern, you can see hemoglobin A2, you can see fetal hemoglobin. Look at the first slide first. You can notice the fact that there is presence of three types of hemoglobins, that is hemoglobin A, which in a healthy person like you and me would be close to 95%. Fetal hemoglobin values would be something in the range of 2%, and hemoglobin A2 values would be in the range of 3%. So this is a normal status for any one of us. If a patient is having a sickle cell anemia, then you will notice that apart from the normal hemoglobins present in the patient, there can also be a presence of extra hemoglobin, that is sickle cell anemia. In sickle cell anemia, this hemoglobin S that is present is the major hemoglobin, and this is absent. Hemoglobin A, you can compare with the superior diagram, is absent. So the message here is that when it comes to diagnosis of sickle cell trait, remember my words, in sickle cell trait in a patient, there can be four hemoglobins, that is hemoglobin S, hemoglobin A, hemoglobin A2 and fetal hemoglobin. There are four hemoglobins found in the trait. But if we changes the question into, and they've done this in the paper, they've said which hemoglobins will be found in patients of sickle cell anemia, then in sickle cell anemia it is hemoglobin S. A is missing, that is why the disease is more severe. So remember the fact that absence of hemoglobin A in sickle cell anemia is the reason why the disease severity is more. Do not be under impression that in sickle cell anemia there will be four different types of hemoglobins. It is rather four different types in sickle cell trait, and in sickle cell anemia what you are gonna have is absence of A, that is why the sickling episodes are gonna be so dramatic. When it comes to beta thalassemia, that is the third image, you will notice the fact that the values of hemoglobin F are definitely increased as compared to normal, whereas hemoglobin A, the values are significantly reduced as compared to normal, the superior diagram. So in beta thalassemia, yes, even in the trait part, we can be having a diagnosis with hemoglobin electrophoresis, but in alpha thalassemia, somehow the test tends to miss, and therefore HPLC is the preferred test for those patients. I'll show you one more slide. If you look at this slide, you can see a special type of hemoglobin coming in, which is by the name of hemoglobin Bart's. Once hemoglobin Bart's comes in, that is one of the most severe form of alpha thalassemia. So only for severe form of alpha thalassemia, you can see that this technique is useful. Otherwise, for the milder varieties, this technique may not be useful, and that is why I have been emphasizing that high performance liquid chromatography or HPLC is the best test for diagnosing any hemoglobinopathy in the exam or in clinical practice, and electrophoresis should not be answered. Let's just summarize the core issues that I have explained for this particular topic. If the question says, what is the screening test to be done for patients of beta thalassemia? The test that you will answer will be naked eye single tube RBC osmotic fragility test. This happens to be a screening test. However, if he says, what is the investigational choice for these patients of beta thalassemia? Then the answer should be given as high performance liquid chromatography. If the question says, what is the treatment of choice for beta thalassemia? The answer would be given as allogenic bone marrow transplantation. But obviously for allogenic bone marrow transplantation, you need a donor, you need finances, you need facilities, and if they are not available, then for survival purposes, you will have to give packed RBCs for these particular patients. Now, if I change the question as that of what is the test to be done for initial screening for patients of alpha thalassemia, the answer would be same: naked eye single tube RBC osmotic fragility test. The IOC for alpha thalassemia would remain the same, the treatment of choice would remain the same. The only difference between the two conditions happens to be the fact that alpha thalassemia would be a patient who would be mostly from, I would say, China or from southern part of Asia, and beta thalassemia is rather relatively more common in India. The chromosomes that are defective are chromosome 16 for alpha thalassemia and chromosome 11 for beta thalassemia. Repeat the fact that HPLC as a test is the best way, and at the same time hemoglobin electrophoresis may not be able to identify mild forms of alpha thalassemia and beta thalassemia. As you can see in the figure, the severe form can definitely be appreciated, that is hemoglobin Barts, which is the one of the severest forms, and in fact hemoglobin Barts can even contribute to development or death of the patient. Why? Because it can contribute to severe anemia. Due to severe anemia, the heart of the baby will fail, and that will cause a swelling all over the body of the child. The child will be developing a non-immunogenic hydros fetalis. This non-immunogenic hydros fetalis is the villain behind the death of the child, and well, you can't do much about it. Coming to the next question. The question said, what is true about von Willebrand disease? Now, to solve this question, you should first know what is the function of the von Willebrand factor. So let me just quickly explain, and then we will look at the various options. Let us look at the normal clotting process. Whenever there is trauma, the first thing that will happen will be there would be a formation of a platelet plug at the site of the trauma. Then would be the activation of the extrinsic pathway of clotting. The extrinsic pathway of clotting operates on two clotting factors 5 and 7. Then there is activation of the intrinsic system of clotting. The intrinsic system of clotting will be operating on clotting factors like 8 and others. Then there would be common pathway, and finally what you are going to have is that there will be conversion of fibrinogen into fibrin, which will initially be fibrin soluble and then is converted into fibrin insoluble due to clot stabilizing factor, and clot stabilizing factor is called as factor 13. Let's look at the steps once again. Platelet plug formation, E for England, extrinsic, intrinsic, then fibrin soluble, fibrin insoluble. What I want you to remember is that von Willebrand factor helps in interlinking of the two steps. That is, it helps in interlinking the platelet plug with the intrinsic system of clotting. And if von Willebrand factor is going to be missing from the body of the patient, then in those circumstances, if I put a cross here, then platelet step will not function properly, intrinsic step will not function properly. Platelet plug, whether it is working properly or not, is tested with the help of what is called as bleeding time. Extrinsic system, whether it is working properly or not, is tested by help of what is called as prothrombin time. Intrinsic system, whether it is working properly or not, is tested by what is called as APTT, that is activated partial thromboplastin time. I want you to remember the fact that if von Willebrand factor will malfunction, then in those circumstances, the first step will malfunction and the third step will also malfunction. Therefore, the bleeding time will also increase, and a third step will malfunction, APTT will also change, but prothrombin time of the patient will remain normal. That is the crux behind von Willebrand disease. It is characterized by absence of a component which acts as a tissue glue. What I mean by tissue glue is that it helps in sticking the platelets to the vessel wall, and in case this is absent in the patient, then the first and the third step malfunctions, though the second step is unaffected, and that is why in these patients prothrombin time is normal in the patient. Based on the explanation provided, the answer to this question is choice number C. If you look at choice A, normal partial thromboplastin time, no, rather it is increased. The platelets in these patients are not decreased. I highlight that again. It is not that the amount of platelets is reduced. It is just the fact that the functioning of the platelets is reduced because they are not able to stick to the vessel wall because there is deficiency of the glue. You see, platelets have to stick to the vessel wall. Now, the glue that is helping the platelets stick to the vessel wall is missing. So, problem is not with the quantity. It is a quality aspect that I am talking about. So, this condition does not have a thrombocytopenia. And in this condition, there will be a prolonged bleeding time because, again, I said the problem is with the quality, and therefore the platelets are not able to bind, and therefore the bleeding time of the patient will be increased. Two options can be easily ruled out because B and D are two contrasting statements: decreased platelets, normal bleeding time. So I would even if I don't know about the disease, B and D I will still rule out because they're very contrasting statements. That leaves me with the remaining two. Remember the fact for the sake of MCQs that prothrombin time is always increased in patients of chronic liver disease, whereas activated partial thromboplastin time is always grossly deranged in patients of hemophilia. Whereas if you read a question in which you find that prothrombin time is normal, whereas the bleeding time of the patient, as you can see on the right hand side, and activated partial thromboplastin time is increased, then the diagnosis should be kept as von Willebrand disease. I repeat the statements once again. Only PT increased in the question, liver disease. Only hepatitis increased in the patient, it is hemophilia. If you find a combo with a hepatitis and bleeding time, that is the first step and the third time deranged in the patient with a normal prothrombin time, it is von Willebrand disease. For these patients, the investigational choice is Ristosine aggregation test. Ristosine is actually I would say a product that behaves like von Willebrand factor. So in patients of von Willebrand disease, the sample will not clot in the absence of obviously von Willebrand. But once you add Ristosine, which is like an artificial von Willebrand, the sample will definitely begin to clot. So Ristosine aggregation test is the best test for diagnosis of patients of von Willebrand disease. And for management of these patients, we shall be giving a von Willebrand factor concentrate which is available. For minor bleeds, obviously you can give desmopressin, but for severe bleeds, we have to give either a fresh frozen plasma or a cryoprecipitate, or ideally situated for these patients, a von Willebrand factor concentrate made by DNA recombinant technology can be given to these particular patients. Most of the time, the MCQs on this topic will also talk about a girl who's having excessive bleeding. You see, the moment you read the question, you know it is not hemophilia, because hemophilia is unlikely to be seen in girls. No, hemophilia is X-linked recessive, hemophilia A. So here, if you read a question, 13-year-old girl with excessive bleeding, which could be like post-dental extraction. She was having this dental caries. The dentist told that we will have to extract the tooth because it is irreversibly damaged. Root canal treatment will not work. So all that's going to happen here is that post-dental extraction in the patient, there is excessive bleeding. They've applied ice, they've applied adrenaline, and because the bleeding is not getting controlled, they came to you. The test that you will write for these patients would be called as coagulogram. In coagulogram, what test will you do in the patient? You will write bleeding time, prothrombin time, activated partial thromboplastin time. The three tests that are written in color blue before you are three components of the coagulogram. And if in the report everything is more except one, prothrombin time, it is a diagnosis of von Willebrand disease from the exam perspective. The IOC for this condition, however, would be answered as measurement of the activity after Ristosine addition to the sample, that is the sample will clot after the addition of Ristosine, which behaves like artificial von Willebrand. Ristosine aggregation test is the investigational choice for diagnosis of von Willebrand disease. Answer to this question happens to be C. A second question on iron deficiency anemia in this exam. What is not true about iron deficiency anemia? I mean, these are like bread and butter for you. You need to get these easy questions out to get to the magical figure of 150. Hypersegmented neutrophils, absolutely not, because that would be a feature that is seen in pernicious anemia. Microcytosis precedes hypochromia. Yes, that is what happens. Usually what you will get in iron deficiency anemia, smaller RBCs, and then they would be not only small, but they will have less hemoglobin also. MCHC less than 50%. Yes, it will always be less than 50%. MCHC is gonna be mean cell hemoglobin concentration. So that is going to be mean cell hemoglobin divided by mean cell volume. What I am trying to say is that in patients of iron deficiency anemia, both MCH and MCV will reduce, and if both reduce by equal amount, the values can remain normal in the patient, and normal values are anyway in less of 34%. So C is definitely a choice which he is just trying to see that are you aware of the fact that in which condition MCHC will be increased. So MCHC would be increased in a condition which I am now showing before you, that will be having small RBCs. The condition which has increased MCHC is hereditary spherocytosis. Look at the mathematics here. In the mathematics, I have simply shown that the RBC is smaller in size. The denominator is becoming lesser. Just look at the mathematics here. MCH is mean cell hemoglobin. No issues with that. But the RBCs are smaller in size. Smaller RBCs would mean the fact that mathematically the ratio will increase, and therefore MCHC would be increased in the patient. Increased MCHC is a feature of hereditary spherocytosis. In iron deficiency anemia, the values tend to remain normal, and they are obviously less than 50%. Normal values are in the range of 30 to 34%. Normal MCHC is in the range of 30 to 34%, and in this condition obviously it will not increase. Commonest cause of anemia in India is iron deficiency anemia. Yes, so I'll just evaluate. D is definitely a correct statement. MCHC is less than 50%. Yeah, the normal values I've told you. Microcytosis precedes hypochromia, correct. But hypersegmented neutrophils, they are the ones, hypersegmented would mean that the neutrophil will be having at least 5 lobes or more than 5 lobes. So hypersegmented neutrophils are the ones which are seen with the pernicious anemia, that is with vitamin B12 deficiency. And therefore this I would say is a relatively easy question that you can pick up right away. Even without this explanation, you can solve this question by just reading the choices, that there would be a hypersegmented neutrophil present in the patient. Moving to the next question. Severity of mitral stenosis is determined by. Now I've highlighted this in the routine lecture of murmurs, but I just want you to pay attention here. Let us assume this is a shunt diagram for mitral stenosis. You can see in the diagram a normal orifice of the tricuspid valve and a narrowed orifice of the mitral valve of the patient. You can notice the fact that on the right hand side, normal amount of blood can flow from RA to LV. But on the left hand side, you can see the fact that the amount of blood traveling through this area is significantly reduced. So point number 1 is that if this orifice is smaller, then blood will take more time to go across this area. That amount of time that is required to transit from LA to LV will become more and more because the opening is becoming smaller. Let me just accentuate this. If I say this opening will become even more smaller, the time required to go from the patient's LA to LV will further be increased, and therefore I can say the fact that the severity is directly related to the duration of the murmur, because the smaller is the hole, more is the time required for the blood to go. Remember the fact severity of mitral stenosis is best determined by diastolic murmur duration. Do not answer intensity of S1. Intensity of S1 in mitral stenosis can be loud or it can be soft. In fact, soft tells you the fact not about the severity. Soft tells you that there is a calcified mitral stenosis. So because of the calcium deposition, the valves will move with less mobility, and the reduced mobility causes a soft S1. Opening snap can be loud, that's a normal happening, but you just can't say it is loud, louder, loudest. You can't rate it, no. And intensity of diastolic murmur is again not a determinant. It is the duration that it will take for the blood to go from LA to LV. That is the most important determinant. So the answer to this question is diastolic murmur duration is the best determinant for severity of mitral stenosis. The answer is choice number beta for this particular question. Malignant hypertension can lead to all of the following except malignant hypertension would be very high blood pressure, usually in excess of 180 by 120 millimeter of mercury, and there will obviously be, due to the high blood pressure, there could be a concomitant possibility of target organ damage in the patient. In these patients, there can be definitely damage to the eyes of the patient, so you would have a hypertensive retinopathy. There could be damage to the kidneys of the patient, so you would be having a renal failure. There would be damage to the brain of the patient, you will have a stroke, but you do not read about respiratory failure in malignant hypertension. Hypertension definitely damages the heart, that can contribute to development of left ventricular hypertrophy. High blood pressure will damage the eyes, so it could result in development of diabetic retinopathy. It will damage the brain of the patient, so it will contribute to development of stroke in the patient. It will damage the kidneys of the patient, and that will contribute to development of renal failure, chronic renal failure in the patient. Multiple organs of the body can be damaged in high blood pressure, including the aorta, and there can be aortic dissection, which could contribute to even mortality of the patient. My point is, guys, malignant hypertension as a word indicates the fact that vital organs of the body, the target organs related to hypertension, are severely affected, whereas the lungs are not affected, and that is why the answer to this question is choice number B. Moving to the next question. What is overall the most common arrhythmia in clinical practice? The answer to this is very straightforward: atrial fibrillation. Remember, the most common arrhythmia in overall clinical practice is atrial fibrillation. If they ask you what is the commonest arrhythmia in geriatric population after 65, the answer is still atrial fibrillation. If he says what is the most common arrhythmia in hypertension patients, the answer is still atrial fibrillation. So this is definitely an answer to 3 questions. Though if he says what is the most common arrhythmia in a COPD patient, then do not answer as atrial fibrillation. The most common arrhythmia in a COPD patient should be answered as multifocal atrial tachycardia, that is MAT. I'll just show you a ECG that is revealing atrial fibrillation. If you look at the ECG, this guy, you can notice there is no very discernible P wave before every normal QRS complex. There's rather a twitching activity. There's rather a twitching activity that is happening before every QRS complex in the patient, but you cannot see a very clear-cut P wave in the patient. So atrial fibrillation or fibrillative waves just at the time where the P wave should be present is a feature of atrial fibrillation. And one more feature that is very characteristic is irregular heart rate. Like look at the RR interval of this guy. I can count 3 large squares and then I can count only 2 large squares. So the heart rate of this patient is definitely varying. Such a situation where you have a variable RR interval is a feature of atrial fibrillation, whereas you can notice these sawtooth waves which are present before every QRS complex. These are like sawtooth waves which are present. The sawtooth waves that are present in the ECG of a patient who's having a macro reentrant circuit which is around the cavotricuspid isthmus is called as atrial flutter. Treatment for both of these conditions is same, though incidence wise atrial fibrillation is more common than atrial flutter. Drug of choice for rate control of both of these medical conditions should be answered as esmolol. The best drug for rhythm control in both of these situations should be answered as ibutilide. Coming back to the question, just remember my facts. The most common arrhythmia in clinical practice is atrial fibrillation, and if it is COPD patient, then it is multifocal atrial tachycardia. Moving my slide. The preferred biochemical marker in patients presenting with myocardial infarction. The best test for diagnosis of MI is beta, that is cardiac specific troponins. That is in MI patients, the values of troponin I or troponin T can be estimated using the standard commercial kits, and these values will definitely be very highly elevated because of necrosis in the heart of the patient. Myoglobin is not a good test because myoglobin is present in skeletal muscle also. So if myoglobin is elevated, I will not come to know whether it is the skeletal muscle that is damaged or whether it is the cardiac muscle that is damaged. And CPK-MB, the disadvantage of this particular test is that it rises after approximately 4 hours, whereas troponin T and troponin I, they rise as early as 3 hours. In fact, most textbooks would say for CPK-MB 4 to 6 hours. I gave you the lower value, 4 hours at least, and trop I can be elevated as early as 3 hours after the onset of MI. So therefore this is overall the best test because it gives you early identification, and if it is present, it is a guarantee that there is a damage which is present in the heart of the patient. So answer to this question is beta. On ECG, ST elevation is seen in all of the following conditions except. You just need to remember causes of ST segment elevation. Yes, MI is a cause and so is acute pericarditis, which means that you have to select between the remaining two choices. The correct answer to this question is delta, that is hypocalcemia, which will be causing a rather a QT prolongation. Let us now look at how to solve this kind of an MCQ. ST elevation is a feature of all of the following except. ST elevation alphabet E can be used to remember electrolyte imbalance. What I mean by electrolyte imbalance is hyperkalemia. Alphabet L would stand for left bundle branch block. Alphabet E would stand for early repolarization variant. Remember my words that there is a possibility that you might come across ST elevation in an asymptomatic guy. He will ask you, doctor, my ECG is abnormal. You will tell him this is a physiological ST elevation. So definitely this can be encountered by you in your practice. VA alphabet stands for choice number A of the MCQ, that is ventricular aneurysm. The structural damage on the surface of the heart results in a ST elevation in the patient. T stands for trauma. The trauma could be with respect to pericardiocentesis. I would stand for ischemic injury, that is myocardial infarction. Alphabet O of elevation would stand for Osborn waves. Osborn waves are a feature that are seen with patients having hypothermia. In fact, the MCQ on Osborn wave was asked in the NEET exam, January 2019. And alphabet N would stand for non-occlusive vasospasm. If you remember this mnemonic of ST segment elevation, the job is done for you. You just need to deploy this in the paper. ST segment elevation is a feature that is seen in the following situations: elevation, and is not a feature of hypocalcemia. Answer to this question would be given as delta. Hypocalcemia, rather you can remember calcium has an inverse relation with QT interval in the ECG. What is the normal duration of the QT interval? 360 to 440 milliseconds. QT interval will be starting from the Q and ending at the T. This particular area is called as the QT interval. Normal duration of QT interval will be 360 to 440 milliseconds. This would be 9 to 11 small squares in the ECG, and if it is prolonged, that would be a hypocalcemia, that is tetany, can cause a QT prolongation in the patient. Most of the time in the exam, they've asked regarding ST versus a QT prolongation. So you just need to remember this information, the mnemonic that I've given, and calcium showing an inverse relation with QT. This would solve your woes with respect to ST versus